So let's show you another case of phacoemulsification in a heart cataract after local anesthesia. Now we are making the main port with 2.75 phaco knife, and now we will stain the anterior capsule, but first you should put air so that the blue dye should not touch the corneal endothelium, and try to remove it as soon as possible, because it also causes toxic anterior segment syndrome. Now putting viscoelastic to inflate the anterior chamber, and now with the help of a cystotome, rhexis. Now rhexis is a very important step here, because usually there is a positive pressure inside the capsule. As you can see, when we gave the nick, the lens matter came out. So in a very slow and smaller gradients we are continuing the rhexis. Now here the anterior chamber got shallower, so I came out. Now I am putting viscoelastic because the rhexis was also getting a bit radial. Now here you can also use Utrata capsule rhexis forceps to keep the rhexis in check, but I continued with the cystotome, and you can see that though the capsule rhexis is not that much round, it is a bit oval, but we have successfully completed it. And now side port for second instrument, and it should be little bit larger for fine irrigation aspiration later. I perform Phaco in a single setting, 350 vacuum, 50 power, and I use dialer as a second instrument. So first of all, I aspirated all the superficial cortex, and now you can see that I am trying to hold the hard nucleus with the help of a Phaco, and now raising it, tilting it, and now chopping smaller fragments. You can see. Now in this way you can rotate it, and now I am coming out putting viscoelastic, because now this Phaco is a bit anterior and nearer to the endothelium, so you should try to come as much out as possible and put as much viscoelastic as possible for the sake of cornea post-op. Now divide it into many fragments. Now it looks very dangerous, but I am totally in control, and we have almost half of the nucleus we have eaten up. So in this way you chop the nucleus, you try to cut it smaller pieces and then remove it, and you put lot of viscoelastic, come out again and again. So this technique is called tilt, elevate and chop technique. With the 50 Phaco power I have done almost all the Phaco. You can also increase the Phaco power in such a hard cataract up to 70 or even 80, and it will decrease the Phaco time further. Usually in such a hard cases the cortical sheets are minimal, as you can see. Now the remaining cortical sheets with the Simcoe cannula. You can also go from the side port if the AC is getting shallower, but if you have made a good main port stepped, then AC will be maintained. Now try to remove all the lens fibers within the bag, and now we will implant foldable IOL. Now following haptic is outside the capsule. Now it's in the bag. Now remove all the viscoelastic because it also causes the toss. And at the end you can do hydration of the ports and your surgery and intracameral moxifloxacin to avoid the chances of endophthalmitis. So that was a case of phaco emulsification in a hard cataract. Thank you very much.